including organizational culture and structure, policies, procedures, and management practices, all combine, I think, to favor support. I offer a few examples for you that emerged from this 2010 or 2011 management review that I mentioned, and just some other observations that I've had from the 2 tours that I've done at USAID. As April mentioned at the beginning, I'm actually a CDC employee on detail to USAID. So I wear kind of 2 hats. I actually wear 1 hat, but it gives me an interesting perspective. Most of these points, by the way, that I'm going to make will not come as a surprise to most of the people in the room or news. And in addition, I think a lot of the points that I'm going to make are consistent with a recent paper by Derek Brinkerhoff, who is here. This was not a setup. I didn't know he was coming. But he has just written an excellent paper with David Jacobstein from our USAID Bureau on Health Policy. I always get this confused. It's Program Policy and Learning. That's right. And it's called Systems Thinking and Institutional Performance, Retrospect and Prospect on USAID Policy and Practice, which I highly recommend. It's a really interesting paper. So let me go through a couple of examples. First, I think that I want to share with you the fact that the mandates that we have are not system strengthening friendly. Congress does not formally request or otherwise require that USAID work on strengthening health systems in the way described in this paper. Furthermore, there is no presidential initiative for health system strengthening, as there is for certain high-profile, high-impact diseases like malaria and HIV/AIDS. Second, I would say that the organizational and operational imperatives in place are support-friendly. As many of you know, health staff at USAID work in a traditional hierarchical bureaucracy with sharply defined roles, responsibilities, and areas of authority, with narrow spans of management control, most importantly, congressionally earmarked funding streams for discrete health programs like TB, maternal health, child health, family planning, nutrition, NTDs, and their related interventions. And these come with standard operational policies and procedures that guide earmarked programming behavior. And there are long reporting lines that reach outside of the agency all the way up to the Hill. So as a result, when those charged with stewardship of these health programs that are funded and earmarked by Congress, when they think about health systems, they tend to look at them, understandably, not through a prism, but through a program-centered lens. And what they often see are system bottlenecks that are impeding the delivery of the targeted interventions and thereby preventing the achievement of their desired short-term results, for which, and this is very important, they are held accountable. They do not necessarily have the bandwidth, or some might say the luxury, to consider the interrelated factors and relationships influencing the performance of the sector as a whole, which impact the performance of their programs, albeit over time. Consequently, they commonly invest in system support interventions to remove the bottlenecks that are encumbering their programs and hampering achievement of the short-term results to which the agency is committed. So let's be clear about one thing. This is perfectly rational behavior. Okay? Health element stewards are responsible and rewarded for the quality of their management of discrete health projects and program pipelines. But one consequence of this behavior for system strengthening is that we have rather limited experience in cross-silo communication, information sharing, or technical collaboration that's related to issues that affect the health sector as a whole. And I would say the third element is that history matters. Grace talked about the WHO building blocks, and I concur. I think that the building blocks have wielded, since they came out in 2007, a substantial influence on how staff at USAID think and talk about health systems, particularly that first line in terms of the building blocks, without diving down into the other parts that you highlighted. And I think that this legacy has limited the conversation until recently about the dynamic nature of health systems and health system strengthening, including the recognition of the relationships, as you were saying, and connections among the different interdependent functions of the system, the presence of multiple information feedback loops, naturally occurring adaptations that emerge and evolve over time in health systems, and the importance of continuous learning. So that's the institutional factors. So putting these institutional factors aside just for a moment, is it true that some individuals don't understand the difference between health system support and strengthening as you describe in your paper, or what the fuss is all about? I think undeniably that's the case. Is it true that some individuals may not be convinced of the value of investing in health system strengthening? I think undoubtedly. And finally, is it true that some individuals think that by investing in disease-specific programs, health system performance can be improved through natural spillover effects? I think the answer is apparently. When I asked this question of a convenient sample of USAID staff with expertise and experience in health systems development in a 2010 survey, of the 66 respondents to the survey, 60% agreed with this proposition. Nevertheless, even if we could successfully educate everyone about the distinction between health systems, strengthening, and support, if we could convince them with evidence of the value of investing in strengthening and push them to provide evidence of natural spillover effects, strengthening would still be this very large rock that we are pushing up a very steep institutional hill. And I offer one case in point, and that's funding. As I mentioned previously, health funds are designated by health programs, and USAID does not currently budget resources expressly for strengthening systems. So you might be asking yourselves at this point, well then, how can you have a Office of Health Systems? How does the budget work? Well, our relatively new and still maturing office receives its money from the 3 health program offices, okay? And we often refer to these offices as investors. But without going into detail, because I'm not allowed to, suffice to say that these core funds arrive in the Office of Health System in 2 streams. One that allows for discretion, and that funding tends towards strengthening, and another stream that is more directed, and that money tends towards support. Okay? But what I would say is that the share of the budget available for strengthening is considerably inferior to the budget that's available for support. Okay? And these core funds, interestingly enough, are relatively small compared to the amount of money that the field missions buy into or allocate to our centrally funded projects. We do not have very good data about the split between how much of that is directed and how much of that is cross-cutting. But I was talking just the other day with one of our managers of a project that we have in our office, and I asked him this question, and he said virtually 100%, maybe 95% of the money that comes in from the field into his project is really directed. It's more towards supporting health, sorry to use that word, but supporting support. Yep. Right? And these funding patterns, as you can see, they create a very strong incentive to be responsive to the investors. Okay? And the prominent role that system support plays, as you might expect, is also reflected in the research agenda. And a key finding of a recent landscape analysis that we did of the research that we do on health systems indicated that research on program or service specific bottlenecks really dominated the portfolio. And that the power of the portfolio to address the scalability and sustainability of short-term gains achieved by these discrete programs is very limited. Okay, so despite a health system portfolio that has both strengthening and support, but that emphasizes support, I think that there are some encouraging prospects for achieving more of a balance between strengthening and support, which, as we said, are both important at USAID. And I'll cite a few examples and then I'll conclude. First of all, the Office of Health Systems that we've been talking about really does provide an opportunity to champion a broader orientation of strengthening while being responsive to the support requests we receive from our investors, and to make the work, and this is important, I think, on strengthening accessible to Congress and to other stakeholders. Second, the office is sponsoring a Marshalling the Evidence initiative, which is attempting to document through various knowledge generation and knowledge synthesis activities the impact of health system strengthening interventions on health outcomes in an effort to convince various stakeholders, both within and outside of USAID, of the value of investing in system strengthening. Third, the office is spearheading with new funds a body of work on domestic resource mobilization within the context of sustainable financing for HIV/AIDS. Now, although the initiative is disease-specific and is being held accountable for increased domestic resources for HIV/AIDS, those involved in this activity acknowledge that they expect more domestic resources for the health sector more broadly. And as you know, and as Grace has put up on her slide, Ebola has generated a heightened understanding of the dangers of fragile health systems. And as a result, there has been a recent surge of interest on the Hill about resource allocation and investments on health system strengthening, which have resulted in multiple discussions between our office and other folks at USAID and legislative staff on the Hill. And there's also been, as you probably know, an emerging conversation in the literature and among practitioners about health system resiliency, trust between communities and health system actors, open information for accountability, and health worker safety, among other topics that have come out of this whole Ebola event. As many of you know, USAID, along with the World Bank and WHO, will also be hosting a Measurement and Accountability for Results in Health Summit in Washington, D.C. from June 9th to the 11th. And one area of focus on that summit will be measuring outcomes for universal health coverage. And speaking of UHC, our Office of Health Systems is promoting the inclusion of USAID priority services in essential packages that countries are developing. We're trying to promote the development of strategies for civil society and the private sector engagement in UHC, and supporting implementation research on universal health coverage in Indonesia through our implementing partner, HFG. During his tenure, Administrator Shah introduced several important organizational and business practice reforms under the rubric of USAID Forward, which has resulted in new processes and mechanisms that promote systems thinking within the agency. And a community of practice has actually emerged around local systems that's shepherded by our USAID Office of Policy Planning and Learning. And it's quite active. And I would refer you again to Derek's paper because there's quite a lot of information about the evolution of systems thinking within USAID, and there are more details about this, so you can get those details from his paper. And finally, an increasing number of USAID staff are participating in the World Bank flagship course on health systems strengthening, health systems reform, which gives people a different orientation and some new ideas about how to think about, talk about, and work on health systems. So in closing, during the 2010 management review that I've referred to, several staff who've been at USAID for a very long time told me that they thought a congressional earmark for system strengthening was the only hope for a well-funded, substantive, long-horizon portfolio of work as a counterweight to the dominant efforts that we see in health system support. Today, in 2015, this is 5 years later, for many, such an earmark remains an aspiration, but something akin to what Emily Dickinson once described as the thing with feathers that perches in the soul. In any case, an earmark alone would not guarantee more money for strengthening, as a lot would depend on how it was channeled through the agency. So all of us who work on system support and strengthening at USAID really need to work together and look for and pursue any and all opportunities to strike the appropriate balance for how the agency engages with health systems around the world. And having worked in multiple bureaucracies in my career, I believe that the challenges that USAID faces in trying to find this balance are not unique to USAID, and I'm hoping that perhaps the discussion that's going to follow will maybe address some of these issues and whether they're relevant in other organizations. That's not USAID. I think we used USAID as a case, but we really would like to expand beyond that.
Absolutely. Thank you, Joe. Thank you very much. And I believe that it's being recorded, and so make sure that if you're speaking, if you're in the back, maybe you could come, because I think that the mics are on the table. So that's my my only request. So now we will open it up for questions, comments, and all kinds of interventions. Systemic interventions, of course.
Yeah, hello, my name is Niranjan. I work for Management Sciences for Health, MSH. And the question I have for Joe, thank you for your remarks, is today in 2015, as you were revisiting, comparing to 2010, I understand that there was a congressionally appointed committee to advise Congress on what should be the vision for the Agency for Health System Strengthening, the Institute of Medicine report I'm talking about. So having done all that work and gathering all the evidence, some of the principles you were talking about,
Right.
what are the barriers now that we have all the information in that report?
Right. Thanks for bringing that up. We have a lot of different activities that we're following in terms of trying to engage stakeholders, and one of the most important ones was early on, USAID commissioned the Institute of Medicine to write a paper about the importance of health system strengthening and why U.S. taxpayers, should invest in this, why this is important. So the review that they did, I think, was a combination of expert opinion and literature review. It wasn't a systematic review of the literature. It was a combination of that, an expert panel. And I know that they made a presentation to legislative staff in Congress. I was just we have someone who's the point of contact for that. I was just asking him the other day, kind of like your question, what happened to that? And he said that there are things that it's a complicated process in terms of the channels of communication, but he says that there's still work going on in trying to get in touch with the right people to make the case to Congress, I think congressional staff, at least at the first step, who would then make the case above. But I don't have any more specific information than that. But that was an early and important. I mentioned earlier marshaling the evidence initiative. That was one of our activities in commissioning this report from the IOM, and I believe it's online now, and everybody can see the report. In terms of the impact that it's had on Congress yet, I don't have a response for you yet because I think that it's still a work in progress about how to get that communication.
Thank you.
Mm-hmm.
Isabel.
I'm really sorry I came late, and I missed most of your talk. I'm Isabel Liddell. I'm from the Pan American Health Organization. Used to be at CAC. Hi, Joe. Haven't seen
Hi,
Joe.
Isabel.
So my comment is, I think, because you sort of asked for a broader perspective, and maybe this was already said, but I think from a global point of view, if you look at the MDGs, it's the same thing. Very vertical, very siloed approaches with the idea being to focus on results. And I think some of that indeed did have an impact on those results, so that's a good thing. And I think there were some attempts to do health system strengthening within that. The Global Fund was providing some money. I'm not sure whether that was really about systems or was it support or health systems. I'm not sure because that's not my area of expertise. But there were some immunizations too. There were some attempts around that. But now we're looking at the SDGs, and I'm so glad that you mentioned universal health access and coverage. I don't remember exactly what the wording is, because I think that, and I was thinking about it, and then you said it. I'm glad you did. But so, I think that is in a way the entry for globally to focus on strengthening health systems, because now it's a global goal. And I think it's a way to persuade donors, and not just the U.S. Congress, but Brits and Canadians and everybody else, to focus on universal health care, which means explicitly focusing on, I think, I'd be interested in what people think, on health system strengthening. So that's one comment. And then from a PAHO perspective, long ago at CDC, I can't even remember what the group was, but there was a lot of work on essential public health functions, right? Which is about health stewardship. Because universal health coverage, the thing that worries me about universal health coverage is it's about health care delivery, primarily, and some of the stewardship that comes around that. But providing health is more than health care delivery. It's about prevention, promotion, working in the community. So it's not just about services, health care. So I would just throw out there the idea that you want to think more broadly about stewardship as part of health system strengthening, and I think it is part of the building blocks and the essential public health functions as one way to organize kind of the work around that. And if people don't know, there's, I think, 9 or 10 essential goals. But POW's done a lot of work on that with the countries in the Americas measuring it, and you know, we've kind of gone up and down with that. We're going to return to it as we also focus on inequity. So thank you very much. Very interesting. Appreciate it.
Thanks, Isabel. I know this is not a shy bunch, so don't even try to fake it.
So my name is Heidi O'Bray. I was with CDC for 12 years. I just joined you. See a theme here. I was in South Africa for the past 10 years. I just joined USAID as a Foreign Service Officer. One of the biggest challenges I found, I was at the Ministry of Health actually in South Africa, and trying to do capacity building and et cetera, and it's extraordinarily difficult. And I think that even if we were given an earmark for HSS and with strengthening UMass, like I would struggle with what do we do with that? Because the enormity of the problem, to get, say, healthcare workforce, you have to look at sort of standards and pre-service training and sort of like, you know, salary. There's so much to do. I think it would be very, very difficult to figure out how do you prioritize, how do you have impact? And I think the other comment that I have, and I really like what you had said in terms of ensuring on the other side, is the recipients of this health system strengthening, because if you don't have that, you're not going to get far at all. And so how do we build the sort of cohesive partnership to give and receive and really driving the joint partnership for HSS? And that's extraordinarily difficult. So it's more of a comment than a question, but I'd be interested to hear sort of what you have to say about that.
Really good comment. Do either of these speakers want to say anything or keep going?
I wouldn't, just in response to that, I mean, I do think that is an additional challenge for a donor to be working in an environment where, as you say, you so much rely on your in-country counterparts' real commitment to this. So I think, you know, in that respect, in terms of, you know, do we do support or strengthening, maybe in some countries you don't really have that commitment, but you don't, and you need to, I don't want to say, you need to scale back your ambitions, you know, in terms of health system strengthening, and realize that you may not reach some of these long-term sustainable goals if the government officials are not on board, if that's not their priority.
I just would say that I think a problem that it poses to agencies, a problem that's posed to agencies, but also to ministries of health when it comes to this issue of support and strengthening. Another question is who's going to pay for it? I mean, for the strengthening part in particular, when it's cross-cutting and you've got, you know, as you say, a very complex landscape and multiple actors and multiple people, how do you, you know, gather enough resources to be able to do that? I mean, that's one of the problems we have at USAID, and so that's why we have this sort of fragmented kind of approach. But I think about results-based financing or performance-based financing in particular on the supply side, and that's a good example of where you're buying an essential package of services. And so there you have the opportunity to leverage across a variety of different programs. And so they're the kinds of interventions I think that we have hope for in terms of developing the system, because they cut across multiple programs and they include multiple financing from multiple groups.
Abdo? Can you either speak up or?
I'm loud. World Bank. Sorry, I'm dressed for the occasion. I'm on vacation today. And I live around the corner. So basically, fantastic paper. We talked about it a long time ago. I think it doesn't address a real challenge, which is a linguistic challenge. I grew up in a world which called things what they really are. We called it health sector reform. Strengthening came in as a politically correct term. No politician wants to reform because reform introduces risk. So we came up with a vague term that could be misinterpreted, and oh my God, it's misinterpreted. It's actually misused. So yes, everybody does what they call it, and they call it health system strengthening, while in your language you're distinguishing between strengthening and support. Really what you're talking about is the difference between support and reform, systematic change. And that's why at the bank we support this control knobs, the idea that you actually have to change something to change results. The other issue, and I brought this up when, Joe, when you opened your office, Tim our director was invited to, he wasn't our director then, and I was on the panel, and we made some comments. And I told you back then, good luck. It's an impossible thing to sell. You put two terms that don't mean much to most people, and you say, I want money for it. It just doesn't sell. So let's stop trying. What we talk about is, are we making health systems more efficient? Are we making them more equitable? Are we getting more value for money? Are we eliminating bottlenecks? Are we achieving results? As long as we keep trying to sell system strengthening, system change, it's not gonna sell. It will only sell if we, and we live in this world, April and I, where our main client is Ministry of Finance, not the Ministry of Health. They want to see results, they want to see value for money, they want to see change. And they don't want to hear vague terms about system strengthening or so. So anyway, said enough.
That's good.
That's really interesting. I always wondered what happened, like, because when I started working in health, it was sort of the tail end of health systems reform, and then all of a sudden it became health system strengthening. So that was you, right?
No Minister of Health worth their soul would agree to a reform.
Right.
Reform means two things. It means what they were doing was wrong. And so it means that it's an admission of failure. It also introduces risk, because if things go wrong, they will be blamed. Obamacare, healthcare reform, these are difficult political terms. And the WHO, and to some extent the bank, bought into this. Because we do not want to make the ministries of health uncomfortable. So we call it system strengthening. Any intelligent person who can market anything they want, they use this term strengthening to whatever they want.
Yeah.
Thanks for the paper, because I think it shows that things have fallen into the strengthening stream in that way. But it's vague, and vagueness is a fantastic way of doing whatever you want.
Now we know.
I think that's very interesting.